we'll talk about dementia, role of MRI. Dementia describes a collection of symptoms that are caused by disorder affecting the brain. It is not one specific disease. Dementia affects thinking, behavior, and the ability to perform everyday tasks. Brain function is affected enough to interfere with the person's normal social or working life.
بس
Dementia
على كيفك على كيفك. لا
can
تستعجلين على كيفك. اوكي.
Dementia can happen to anybody, but is more common after the age of 65 years. People in their 40s and 50s can also have dementia. Types of dementia. We have Alzheimer's disease accounting for 60%, vascular dementia accounting for 20%, Lewy body dementia accounting for 10%, frontotemporal dementia less than 10%, others. Alzheimer's disease is a common neurodegenerative disease responsible for 60 to 80% of all dementias and imposing a significant burden on developed nations. It is the result of accumulation and deposition of cerebral amyloid beta and is the most common cerebral amyloid deposition disease. Risk factors include advanced age, female gender, current smoking, family history of dementia, mutation of amyloid precursor protein, Down syndrome, chronic inflammation like psoriatic arthritis. Clinical presentation. We have a classical typical Alzheimer's disease and atypical Alzheimer's disease. The typical patient with Alzheimer's disease will present initially with integrate episodic memory deficit. Over time, often years, the disease progresses with eventual involvement of attentional and executive process, semantic memory, praxis. Neuropsychiatric symptoms are also common and eventually affect almost all patients. These include apathy, depression, anxiety, aggression, agitation and psychosis, delusions, and hallucinations. Atypical variant of Alzheimer's disease are characterized by slowly progressive focal cortical atrophy and symptoms and signs matched to the affected area like posterior cortical atrophy, frontal variant of Alzheimer's disease, minority of cases with predominant semantic dementia. Pathology. Alzheimer's disease is characterized by the accumulation within the brain of cerebral amyloid beta, forming neurotic plaque, neurofibrillary tangles, and eventually progressive loss of neurons. Cerebral amyloid beta particularly deposit in association areas of the neocortex, the posterior cingulate, and precuneus, as well as the limbic cortex. Although the reason for this distribution has not been elucidated. Radiographic feature. Although CT is able to demonstrate the characteristic pattern of cortical atrophy, MRI is more sensitive to these changes and better able to exclude other causes of dementia like multi-infarct dementia, and as such is the favorite modality. In addition to structural imaging, molecular imaging with PET is increasingly of value in the diagnosis of Alzheimer's disease. Brain staging for Alzheimer's disease on imaging show the sequential involvement of various structures. As we say, stage 1 and 2, we have earliest involvement of entorhinal cortex. Stage 2, 3, and 4 will involve limbic system and hippocampus. Stage 5 and 6 involve cortex precuneus, in particular with temporal lobes. MRI protocol in dementia, we have sagittal T1 weighted 3D isotropic voxel, traditional flare, traditional T2 weighted, traditional T2 star. MRI. The primary role of MRI and CT for that matter in the diagnosis of Alzheimer's disease is the assessment of volume change in characteristic location, which can yield a diagnostic accuracy of up to 87%. Unfortunately, such volume loss is not apparent early in the course of the disease. The diagnosis should be made on the basis of two features: mesial temporal lobe atrophy, particularly hippocampus, entorhinal cortex, perirhinal cortex, temporoparietal cortical atrophy. Mesial temporal lobe atrophy can be assessed either directly or indirectly. Direct assessment is by measuring the hippocampal volume, hippocampal and parahippocampal volume, and indirect assessment by measuring the parahippocampal fissure. These measures have been combined in the medial temporal atrophy score, which has been shown to be predictive of progression from mild cognitive impairment to dementia. Here we have the MTA scale for medial temporal lobe atrophy. Score is based on visual rating of the width of the choroidal fissure, the width of the temporal horn, and the height of the hippocampal formation. We have MTA scale 0, we have no atrophy, as we see here. Score 1, only widening of the choroidal fissure. Score 2, also widening of the temporal horn of lateral ventricle. Score 3, moderate loss of hippocampal height. Score 4, severe volume loss of hippocampus. Less than 75 years, score 2 or more is abnormal. More than 75 years, score 3 or more is abnormal. In addition to medial temporal lobe atrophy, parietal atrophy also has a positive predictive value in the diagnosis of Alzheimer's disease. Atrophy of the precuneus is particularly characteristic of Alzheimer's disease. This is particularly the case in young patients with Alzheimer's disease, as known as presenile Alzheimer's disease, who may have normal MTA score. This is often best seen on the interhemispheric surface of the parietal lobe by examining the posterior cingulate sulcal and parieto-occipital sulcal size and degree of atrophy of precuneus and cortical surface of the parietal lobe. This has also been combined into a scoring system, posterior atrophy score of parietal atrophy, as known as CODAM score. Here we have the CODAM score for parietal atrophy. In grade 0, we have no cortical atrophy, closed sulci of parietal lobe and cuneus. In grade 1, we have mild parietal cortical atrophy, mild widening of the posterior cingulate and parieto-occipital sulci. In grade 2, we have substantial parietal cortical atrophy and substantial widening of the sulci. Grade 3, end stage knife blade atrophy with the extreme widening of the posterior cingulate and parieto-occipital sulci. In nuclear medicine, SPECT and PET are able to detect regional hypoperfusion, hypometabolism, and biparietal and bitemporal distribution. We have amyloid PET, tau PET, and FDG PET. Here we have sagittal SPECT image of a healthy brain. Here we have sagittal SPECT image of a patient with Alzheimer's disease. As we noted, there is hypoperfusion in the temporal parietal region. We have sagittal FDG PET patient with Alzheimer's disease hypometabolism in the temporoparietal region. Treatment and prognosis. There is no cure for this disease. Some drugs have been developed trying to improve symptoms or at least temporarily slow down their progression. Cholinesterase inhibitor, partial NMDA receptor antagonist, medication for behavioral symptoms, antidepressant, anxiolytic, antiparkinsonian, anticonvulsant. Second type of dementia, we have vascular dementia. Vascular dementia is thought to be the second most common cause of dementia after Alzheimer's disease. It can sometimes be distinguished from Alzheimer's disease by a more sudden onset and association with vascular risk factor. Vascular dementia can be characterized by its stepwise deterioration with periods of stability followed by sudden decline in cognitive function. It is primarily seen in patients with atherosclerosis and chronic hypertension and results from accumulation of multiple white matter lesions or cortical infarcts, although cerebral hemorrhage can be variably included. Radiographic features, CT MRI. Both CT and MRI are able to provide evidence of ischemic damage. However, MRI is more sensitive, especially to white matter small vessel ischemic chains, as well as to microhemorrhage seen in cerebral amyloid angiopathy and chronic hypertensive encephalopathy. On MR, white matter hyperintensities and lacunes, both of which are frequently observed in the elderly, are generally viewed as evidence of small vessel disease. The Fasicas scale provides an overall impression of the presence of white matter lesions in the entire brain. It is best scored on transverse flare or T2 weighted image. The Fasicas scale, we have score 0, no or single punctate white matter lesions. Fasicas 1, we have multiple punctate lesions. Fasicas 2, we have beginning of bridging of the lesions. And Fasicas 3, we have large confluent lesions. Fasicas 1 is considered normal in the elderly. Fasicas 2 and 3 are pathological but may be seen in normally functioning individuals. Here we have vascular dementia, no medial temporal lobe atrophy with multiple white matter lesions Strategic infarction. Strategic infarction are infarction in areas that are crucial for normal cognitive function of the brain. These areas are summarized in the table: cerebral artery, parieto-temporal, temporo-occipital association area, angular gyrus, posterior cerebral artery, paramedian thalamic, inferior medial temporal lobe. Watershed infarction, superior frontal or parietal, lacunar infarction, bilateral thalamic. Bilateral strategic infarction are best seen on transverse flare or T2 weighted sequences. Here we have the image shows bilateral thalamic infarction, lesion often associated with cognitive function. Cerebral amyloid angiopathy. Dementia may be the clinical presentation in cerebral amyloid angiopathy, a condition in which amyloid is deposited in the vessel wall of the brain. The result is hemorrhage, usually microhemorrhage, but also subarachnoid hemorrhage or lobar hematoma may occur. On MR, the T2 star sequence will show multiple microhemorrhage, typically in a peripheral. نعم دكتور.
ممكن شويه السرعه مالتك تقلليها لانه يعني كتبوا لك بالكومنت انه انت شويه سريعه.
اوكي
دكتور. على كيفك شباب.
على كيفك يعني مو بس تقريهن انت شويه تعني بالكلام.
واشري على الصور ورا تقرين التكست اكشري قولي هاي مايكرو هيموريجز. ما يخاف مو انت تقرين وتاشرين انت قولي هذه واشري يعني لا تستعجلين. على شنو الاستعجال؟ هو المهم ايش قد شو اسمه الاودينس المستمع والمشاهد يطلع عنده نسبه من فاهمه من الدمنشيا، وهذا الفكره بابا. على كيف؟ ايه على كيف.
اوكي ان شاء الله. On MR, as we see here, the T2 star sequence will show multiple microhemorrhage, as we see here in this photo, which is typically peripheral in location, as opposed to hypertension. In hypertensive microhemorrhage, the microhemorrhage will be central in the basal ganglia and the thalami. In addition, flare will reveal moderate to severe white matter hyperintensities, Vasigas grade 2 or 3. As we see here in this photo, we have multiple peripherally located microhemorrhage in a T2 star images in patient with cerebral amyloid angiopathy. Third type of dementia, we have frontotemporal dementia, Pick's disease. Dementia characterized by the presence of Pick's bodies within the neurons, accounting for less than 10% of the primary degenerative dementias. Behavioral, motor, or speech disorder tend to dominate the early clinical stage rather than memory loss. We have three types of frontotemporal dementia: behavioral variant, progressive non-fluent aphasia, semantic dementia. Frontotemporal dementia is a major cause of young onset dementia, with most patients, 60%, being diagnosed between 45 to 60 years and 10% being diagnosed less than 45 years old. Radiographic features in frontotemporal dementia, imaging play important role in the diagnosis as the findings are easy to recognize. Radiological findings are pronounced atrophy of frontal and or temporal lobes. In some forms of frontotemporal lobe dementia, the atrophy might be strikingly asymmetric. Example, in semantic dementia, a disease subtypes with progressive aphasia and left-sided temporal lobe degeneration. Here we have a brain MRI of female 65 years old with frontotemporal dementia. As we see, there's cortical and white matter atrophy of the frontal lobes is clear in all images, as we see. Here we have frontotemporal lobe dementia, T2 weighted and flare with knife blade atrophy of the left temporal lobe with normal right temporal lobe. Here we have semantic dementia. As we say, there is asymmetric frontotemporal lobe atrophy. We see here in T2 and flare, there is the marked left-sided predominance temporal lobe atrophy. Lewy body dementia. A dementia characterized by the presence of Lewy bodies composed of alpha-synuclein and ubiquitin proteins within neurons. is a neurodegenerative disease related to Parkinson's disease. Dementia with Lewy bodies present in older patients, onset typically in 50 to 70 years of age, and is sporadic. Clinical presentation. Typically, patients first presents with a frontal type dementia with little in the way of memory deficit early in the course of the disease. Core features include fluctuating cognitive impairment, especially in executive function, attention, and alertness. Visual spatial impairment include visual hallucination. Concurrent Parkinsonian symptoms may be present but are less common, more frequently occurring years after the onset of dementia. Pathology. The characteristic features of dementia with Lewy body is not surprisingly the accumulation of Lewy bodies throughout the brain. We have Lewy bodies is seen in greatest concentration in the midbrain, hypothalamus, basal ganglia, inferior olives, brainstem reticular formation, and dentated nuclei of the cerebellum. Radiographic feature. MRI is the modality of choice to structurally imaging the brain. Functional imaging with a SPECT PET is also useful. The role of imaging is limited in Lewy body dementia. Usually, the MR of the brain is normal, including the hippocampus. When we see the hippocampus is normal, this finding is important as it enables us to differentiate this disease from Alzheimer's disease, which is the main differential diagnosis of Lewy body dementia. Nuclear imaging can be used to demonstrate an abnormal dopaminergic system, so-called DAT scan. MRI features reported include generalized decrease of cerebral volume, most marked in frontal lobes, parieto-temporal lesion, enlargement of the lateral ventricle, relatively focal atrophy of midbrain, hypothalamus, substantia nominate. Here we have axial MRI T1, non-specific change in dementia with Lewy bodies. There is atrophy mostly clearly seen in ventricular enlargement. Nuclear medicine. Although frontal and temporal hypoperfusion can be similar to that seen in Alzheimer's disease, occipital hypoperfusion and the cingulate island sign, which mean preserved metabolism of the posterior cingulate on SPECT and PET, may aid in differentiation from other types of dementia, especially Alzheimer's disease. As we see here, we have a patient in FDG PET imaging of patient with Alzheimer's disease and patient with Lewy body dementia. The red arrow here indicate posterior cingulate island sign, which means the posterior cingulate is relatively preserved and spared and floats in sea of glucose, and there is hypometabolism in the occipital area. While in Alzheimer's disease, a reverse pattern can be appreciated where the occipital cortex is only mildly affected in the early stage next to severe metabolic loss of posterior cingulate. Some other diseases that causes dementia. Creutzfeldt-Jakob disease is a very rare and incurable neurodegenerative disease caused by a unique type of infectious agents called a prion. The first symptoms is rapidly progressive dementia, leading to memory loss, personality change, and hallucination. The disease is characterized by spongiform changes in the cortical and subcortical gray matter with loss of neurons and replacement by gliosis. The abnormalities can sometimes be detected on FLAIR, but are most conspicuous on LEWY sequences affecting either striatum, the new cortex, or a combination of both. Here we have a case imaging of MR imaging, which are FLAIR and LEWY, of patient 65 years old with definite sporadic Creutzfeldt-Jakob disease after 4 months of disease. There is extensive signal and hyperintensity, including the cingulate gyrus, the frontal superior gyrus, the occipital gyrus, and the insular and the temporal medial gyrus, and the angular supraparamarginal gyrus. The basal ganglia have normal signal intensity. These changes in signal intensity are easier to identify on LEWY than on FLAIR images, as we see here. Huntington disease. Huntington disease is a hereditary neurodegenerative disease, autosomal dominant trait, but often de novo mutation, and can present with early onset dementia as well as chorioathetosis and psychosis. Imaging show characteristic atrophy of caudate nucleus and subsequent enlargement of frontal horn of lateral ventricle. Here we have a case of Huntington disease. We have T2 and the flare. There is a significant bilateral atrophy in caudate nuclei and putamen with high signal on flare and T2 consistent with gliosis, as we see here. Last, we should know normal aging from other types of dementia that cause atrophy. The findings in a normally aging brain can overlap with the finding in dementia, as implicated earlier. There may be some degree of atrophy, though mainly of the white matter, with increasing prominence of the perivascular virtue-Robin spaces and non-specific frontoparietal sulcal widening. There may also be some degree of medial temporal lobe atrophy. In normal aging, an MTA score of 2 for individuals older than 75 years old of age may be normal. As the brain ages, there is an increasing deposition of iron in a specific area of the brain, mainly the basal ganglia, a nucleus rubber, paras reticularis of the substantia nigra. There also may develop a rim of high signal intensity on T2 weighted and flare images around the ventricles, known as cups and bands, as seen in next slide. A limited amount of white matter hyperintensity, physicals grade 1, may be seen in normally aging brain. Lacunes are always pathological. As we see here, in normal aging brain, we always notice there is a caps and bands. Summary: assessment of MR in dementia. An MR study in patients suspected of having dementia must be assessed in a standardized way. First of all, treatable disease like subdural hematoma, tumors, and hydrocephalus need to be excluded. Next, we should look for specific signs of dementia. When we see global atrophy, we should go with either vascular dementia or normal aging according to Vasical's scale. When we see medial temporal lobe atrophy, we should go either with Alzheimer's disease or frontotemporal lobe dementia. When we see frontal atrophy, we should go with frontotemporal lobe dementia. When we see white matter lesions, we should go with vascular dementia or normal aging. When we see strategic infarct, this is vascular dementia. References. Thank you.